Now in septic shock there's vasodilation and the capillaries dilate as well, meaning that fluid from the plasma can escape into the tissue spaces. So these patients can actually be quite hypovolemic. So initial fluid resuscitation is quite important, giving them intravenous fluids. And giving intravenous fluids is especially important if the patient has got lactic acidosis. And we might need to give quite a lot of fluids as an initial resuscitation for these patients. And we titrate this in the usual way with central venous pressure, mean arterial blood pressure, urine output, and of course the patient's oxygen saturations. So initial fluid resuscitation, quite important in septic shock, well, very important, essential. We also want to take cultures to diagnose this condition, because it's normally going to be caused by a bacteria, and we want to find out what bacteria it is so we can give the appropriate specific antibiotics. So we might take blood cultures, for example. But also we want to take cultures from areas where we suspect there is infection. So urine for culture and sensitivity, cerebrospinal fluid for culture, exudate from potentially or actually infected wounds, sputum for respiratory infections, to culture it, identify the sort of bacteria. And we can do that quickly because we mustn't delay giving antibiotics. Now we're not going to know the specific organism, so really it's the antibiotic which is most likely to be effective against the bacteria which most commonly cause that particular infection. And we want to use broad spectrum antibiotics. So initially, almost straight away, as soon as the cultures are taken, certainly within an hour of the patient being admitted, they should be having large doses of intravenous antibiotics, really as soon as possible. For example, if someone's got meningococcal septicemia, delaying antibiotics by a few minutes can alter the prognosis and mean that the patient suffers very severe morbidity or even mortality as a result of the infection because the antibiotics were delayed. So as soon as the culture's done, early antibiotic therapy, broad spectrum in the first instance. Then later on, when we get the results of the cultures, we can modify the antibiotic therapy to give something which is more specific to the particular organism, an antibiotic that the particular organism is sensitive to. And also in sepsis, we want to think about the cause or the focus of the sepsis. So where is the infection coming from? And this is called source control. We want to control the source of the infection. So if there's a perforation in the gastrointestinal tract, we might consider closing that surgically. Abscesses, although it depends if the patient's fit for surgery. If the patient's septic, they might not be fit. But we need to think about controlling the source. Abscesses, we can drain abscesses very often without open surgical procedures. So we can drain abscesses, getting rid of pus and infected material. And we want to debride necrotic material where we can. This might be especially important in burns patients, where there's a large volume of necrotic material causing infection, because septic shock is a common complication of burns if they're not well managed. Getting rid of that necrotic material. We want to remove any potentially infected devices as well. Even just a cannula in a patient's arm can develop a film of staphylococcal organisms over the infecting the device, or if there's any long lines in the patient, these can become infected and cause a septic shock. So if a patient has any indwelling intravascular devices, we have to have a high index of suspicion that that device could be causing the infection, and we need to take that device out. Once you've taken it out, do send it for microbiology, culture and sensitivity if that test is available for you. It's also worth making sure there's no infected tampons present in the vagina as well, and certainly take those out if they're present. Symptomatic therapy is going to involve oxygenation, of course, vasopressor drugs such as norepinephrine, noradrenaline or dopamine to try and maintain adequate blood pressure, or inotropic therapy such as dobutamine, again to try and stimulate the contraction of the myocardium, trying to keep the blood pressure up, trying to maintain the health of the patient's organs, trying to keep the organs perfused while we wait for the antibiotics to get rid of the infection and while we get rid of the source of the infection.